All right, let's dive right into this clinical review on sickle cell crises. If you're on the front lines managing these complex and often really challenging presentations, well, this explainer is for you. We've designed it to be a super high-yield resource for your practice. So let's get to it.
Now, before we really jump in, just a quick note. This whole review is specifically tailored for practicing clinicians and, anyone out there prepping for specialty exams. The content itself is distilled from a fantastic guide by Dr. Mohammed Mohammed, and we absolutely want to give him full credit for his work. It's the foundation for our whole discussion today.
So, here's our game plan. We're going to start with the big picture, right? What a crisis actually looks like clinically. Then we'll zoom in on the specific types you're likely to encounter. We're talking vaso-occlusive, aplastic, and sequestration. From there, we'll get into the nitty-gritty of general and advanced management, and then we'll wrap things up with the super important topic of long-term prevention.
Okay, so what really defines sickle cell disease in the clinic? Well, at its core, it's this condition where you have these periods of, relative wellness that are suddenly and violently interrupted by these severe crises. So our first step is to really get a handle on the different forms these crises can take.
You can pretty much break the crises down into a few main buckets, like you see here. You've got here classic vaso-occlusive crisis. That's the one most people think of. Then there's the incredibly dangerous acute chest syndrome, which we'll definitely dig into. We also have two critical anemic crises we have to tell apart: aplastic and sequestration. And finally, you have crises sparked by infection, which, let's be honest, is often the match that lights the whole fire.
Let's start with the most common presentation of them all, the vaso-occlusive crisis. You'll hear it called a thrombotic crisis, or sometimes just simply a painful crisis. This is the clinical picture that most of us, clinicians and patients alike, associate with sickle cell disease.
Now, if there's one thing you take away from this slide, let it be this. A vaso-occlusive crisis is a clinical diagnosis. I'll say that again. It's a clinical diagnosis. There's no lab test that's going to pop up and say, yep, painful crisis. You make the call based on the patient's story in the context of known triggers, like an infection, being dehydrated, or low oxygen, which cause these sickled cells to just jam up the small blood vessels, kind of like a traffic jam.
And this infarction, this tissue damage, it can happen basically anywhere. But there are some really critical sites to watch out for. The brain, the lungs, the spleen, these are all major targets. In the bones, it can lead to devastating avovascular necrosis, especially in the hip. And a really classic sign in children, dactylitis, that painful swelling in their hands and feet you see there.
Now, a particularly nasty form of vaso-occlusion is something called acute chest syndrome, or ACS. Basically, this is when that traffic jam happens inside the tiny blood vessels of the lungs. And clinically, it presents exactly how you'd think it would. The patient is short of breath, they have chest pain, and you see new infiltrates on their chest x-ray.
Managing ACS requires you to move, and move fast. It's a multi-pronged attack. Number 1, aggressive pain relief. Number 2, respiratory support with oxygen. 3, get antibiotics on board early, because it's almost impossible to tell if an infection is hiding in there. 4, transfusion is absolutely critical to boost oxygen levels and stop more sickling. And finally, incentive spirometry is vital to keep the lungs from collapsing.
And just to be crystal clear about how serious ACS is, this one statistic really says it all. It is the most common cause of death in sickle cell patients after they leave childhood. This just hammers home why spotting it and treating it aggressively is so critical.
Okay, let's pivot a little bit and talk about the anemic crises. So your patient comes in and their hemoglobin has just cratered. It's absolutely vital that you can tell the difference between an aplastic crisis and a sequestration crisis, because as we're about to see, how they happen and how you manage them are worlds apart.
This table right here holds one of the most important clinical pearls in this whole review. Seriously, the key to telling these two crises apart comes down to a single lab value, the reticulocyte count. Think of it this way. In an aplastic crisis, usually from parvovirus, the bone marrow factory literally shuts down, so your RIT count is low. But in a sequestration crisis, where blood is getting trapped in the spleen, the bone marrow factory is working overtime to compensate, so your RIT count is going to be high. That one test points you down the right path.
So regardless of what specific type of crisis is going on, there are some foundational management steps that apply almost every single time a patient presents. These are your immediate must-do actions.
Think of this as your immediate action protocol.
It starts with analgesia, and I mean aggressive analgesia. These crises are incredibly painful, so strong pain relief, often with opiates, is step one. Next, rehydrate the patient. It tackles one of the most common triggers head-on. Then, get them on supplemental oxygen to improve tissue perfusion. And finally, always consider antibiotics if you have even a hint of suspicion that an infection is brewing.
All right, let's talk about transfusion. It's a cornerstone of management for sure, but it is not a one-size-fits-all solution. We have to be really clear about the difference between a standard top-up transfusion and an exchange transfusion, because they have totally different, even opposite goals.
This slide just lays it out perfectly. On the left, you've got your standard transfusion. It's just additive. You use it for severe anemia or before surgery, and the goal is simply to increase the blood's oxygen-carrying capacity. The key thing here is you are not trying to quickly lower the percentage of that sickled hemoglobin, the HbS. Now look at the right. An exchange transfusion is an emergency move for things like a stroke or severe ACS. Here, the goal is the complete opposite. You are actively taking the patient's sickled blood out and replacing it with the specific goal of rapidly and dramatically slashing that HbS percentage to stop a life-threatening disaster in its tracks.
So far, we've been focused on putting out fires, right? Acute management. But the real end game is to prevent these crises from ever happening in the first place. So let's look at the key strategies for long-term prophylactic care.
Long-term prevention really stands on two major pillars. First up is medication, specifically hydroxyurea. What it does is it boosts levels of fetal hemoglobin, HbF, which gets in the way of the sickling process. It's proven to reduce how often painful crises happen. The second pillar is all about preventing infection. Because a lot of patients have spleens that don't work well or at all, they are incredibly vulnerable to certain bacteria. This makes the pneumococcal vaccine, given every 5 years, an absolute non-negotiable part of their care.
And that brings our clinical review to a close. We've gone through the different types of crises, how to manage them in the moment, and how to prevent them long-term. But I want to leave you with this final question to really think about in your own practice. We have these effective tools like hydroxyurea and vaccines, so why do patients still show up in crisis? What is the biggest real-world hurdle in prevention? Is it about patient adherence, access to care, social factors, or something else entirely? That's a crucial question to take back to your clinical work.